So, are you ready to go back? The main thing that often happens is that tends to be a bit of a subjective. Sorry, it's in red down here at the bottom, which isn't great. It tends to be more of a subjective decision that's get made by one or two individuals based upon their area of expertise. So, if we take somebody that has a ACL injury, for instance, and they've had their surgery done and they're 6 weeks down the line, let's just say that they're a professional footballer. Maybe, they need another, they're very close to the start of the season. There's a lot of pressure from the team for this player to be declared fit. How do we go about that process? And I think that that's the really important thing that we need to figure out. Who's responsible for it? Is it the surgeon's job? Just because he did the surgery or she did the surgery, is it their call as to whether the player can go back? Is it the physio? Because they've been involved with the rehab process? The trainer, because they're supposed to be the ones making sure these guys are fit? So the whole team needs to be involved, and that dynamic needs to be very clearly understood. The first person that we need to look at is the player. Are they confident to go back? Are they ready to go back? Are they motivated to go back? Because if they're not, you're going to have a lot of hesitation from your player. Whether they're an 8-year-old going to go back to mini league, or whether they're a professional athlete. If you've got a pro going into contact situations at high-level elite sport and they're not confident to go back, but they're getting pushed to go back, they're going to be hesitant, and their risk of getting injuries are going to be much, much higher. So as a surgeon or as a physio or as a trainer, the first part of your return to play assessment needs to be looking at that player, trying to understand them on a psychosocial level. Are they confident? Do they look eager to get back or not? And if you see hesitation, already you're going to start to make the little crosses. Okay, so whether that that's a difficult call, because very often you can't say you don't look ready to go back. You look scared. You've got to be able to say to them, listen, at a later stage, I think we need to continue the rehab. And you need to explain it to them on a much more objective level. So let's just say the player looks super keen to go back. They're very motivated and they want to get there. You've done the surgery. You've done a fantastic job. The ACL looks great. Everything looks absolutely fine. The imagery looks really good. What do you do at that point? Do you say, yes, you can go back? And the reason I ask this question is because the ISL's just recently started, and almost every single one of the cases where the club had applied to us for a player's contract to be terminated because they were unfit, the amount of medical evidence to support that claim, this is to cancel somebody's contract and get rid of all of his money in the most lucrative league that player is going to play in. I mean, these are pretty big decisions that are getting made for that player, right? All of those reports that came back were insufficiently motivated by the medical team. Okay. The majority of the time, I'm sorry to say, the physios and the trainers were not giving enough information. And the rest of the time, when there were doctors in support of that, they were not giving enough information. So the general trend was a small one-liner, maybe 2 paragraphs about the history, the general history of the player, and then a few pictures, like you said, insufficient amount of imagery to support that from, be it an X-ray or an MRI. So we're deciding this guy's livelihood based upon a quick little put together. So if you guys are in that situation in the future, somebody puts you in the hot seat and says, listen, you need to make a call on this. You don't necessarily, if you don't feel that you have all the required skill sets to make that call, it's absolutely fine. The majority of us don't have all those skill sets. I don't have all those skill sets because I wasn't in the theater when that surgery was getting done. But I need to know who's in my team. Who can I say, right, has the surgeon seen this? Have they reported on it? Has the physio been involved? What did the physio assess? How did they do their rehab? And where was the trainer? What tests have been done? So for me, all of these 3 people are hugely important in this person's return to play, regardless of the fact that the support is also very important. So when I say support, if you're looking at a professional player, the managing team, they have an agenda. Sometimes their agenda has got nothing to do or is not aligned with the player's agenda. So we're going to have to look to safeguard the player in that situation as well. And perhaps they're a youngster. So then the support becomes the parents. And at that time, sometimes the parents as well need to be worked on because they may be overprotective and holding their children back, or they may be a little bit too ambitious in trying to get their youngsters back. And often that's where you're going to pick up, the pointer's not working, that's where you're going to pick up that the youngster's apprehension, nervous at going back. Right, so from there, what do we look at? There are two main areas that I think are really important. From a clinician, the majority of the people in this room, we need to do the basics from an injury point of view. We need to make sure that we've understood and quantified pain. So, you're going to do it as an interview. You're going to find out from the individual how they feel about it. But it's important to document it as well. Have it documented, and I'll explain why afterwards. Make sure that their activities of daily living are also have been assessed, so that there's no symptoms at all or limitations on a daily basis. Because if they're struggling on a day-to-day basis, what does that let me? Oh wow, that's much better. Thank you. So if they're struggling on a day-to-day basis, then they're not going to be able to play sport. I mean, if you think about all of the forces and the pressures that go through your body when you're playing sport, they far exceed what we do on a day-to-day basis. So if they've walked into your office and you say, how are you? Yeah, I feel good. You want to go back to playing sport? Absolutely. I'm super motivated. Do you have any pain? No, I don't. Okay, so that's a 0 on your visual analog scale. Yes, it is. Okay, so tell me about, when you wake up in the morning. Yeah, I'm absolutely fine the whole day. I can play sport. I can do everything. I just have pain for 5 minutes when I wake up in the morning. It's stiff and it's sore. Doesn't mean that you're going to fail them, but just keep that as a note, right? It's just helping you develop that whole picture. Abnormal behavior, kicking, giving way, numbness, weakness, the whole gambit of all your red flags or your things or your yellow flags that might make you suspicious that the structure or the integrity of the joint is not there. So check and make sure that there's no mention of abnormal behavior that might make you think that there's a special test that you need to do. So then in normal function, we want to make sure, first of all, that all the special investigations are checked. Now, this is where I find a lot of problems come in because we're too reliant on special investigations. The MRI machine or the X-ray machine is deciding whether this player is going to go back to sport. The majority of the times, we're going to see soft tissue abnormalities on imagery long after the player is fit, long after the player is playing again. So yes, it is important to make sure that we're looking at all of the imagery and all the investigations that have been done, but they are by no means the definitive criteria in deciding whether that person is fit to play or not. Okay, they're going to help us guide. So we're going to look at posture, we're going to look at palpation. It's important to touch that area because often if you've got a player that's perhaps trying to convince you that they're fit, which can often happen as well, by starting to get very close to that joint, you're going to face a lot of apprehension. So touch tissues, make sure that that on palpation things are absolutely fine, and then that there's no negative effect. And then finally, look out for your active and passive ranges of motion. So if a trainer has been involved, sometimes you can have athletes that pass tests, but when you are then assessing them, you'll find that the knee doesn't go through full range of motion. There's not full extension within the knee. Now, that might be fine now, but we know that towards the end of the season, 3 or 4 months from now, if you haven't attained proper passive and active range of motion of that joint, we're just incorrectly loading that joint. So yes, he can pass his test now, but we know 3 or 4 months down the line, he's going to have loads of problem coming from that joint. So that's also going to be something that's going to feed into your decision on whether you decide that this person has recovered from their injury or not. And then finally, all your special tests. If any of your special tests are positive, that's a big problem. All right, so then at that point in time, from a clinician's point of view, we're going to be saying, listen, this anterior drawer is positive, or this apprehension test is positive. This is a big issue. We haven't got anywhere near where we need to be able to get back onto the sports field. So I think from a clinician's point of view, we need to make sure that we're covering all of our bases. A good, really solid assessment. I think I'm going to be able to show you an example of an assessment at the end, yeah? That other document, the PDF file? Yeah, perfect. So I'll just run you through it very quickly at the end. Your trainer, now the trainer, in a practical sense, is often the physio, because budgets don't allow to have huge, big sports medicine teams. So the other problem that we face traditionally in South Africa, I know it is the case, and I know it's the case in India as well, physios are not trained on sports medicine adequately. The fundamentals of application of sports medicine. So he's going to stand there in the room with you, and he's going to say this player's fit to play. But has he or she adequately tested that person? And this is what you need to check, guys, because they're part of your team. And like it or not, if the player goes back and gets injured, especially if there's been a surgery, they're going to come back to the surgeon and they're going to say, but what went wrong? Often it's not your fault. Often we haven't really got the player fit. Their injury is better. Your job has been done, right? You fixed them. That doesn't mean they're fit. And if they're not fit, they're going to get injured again. So these are the kinds of aspects that need to be covered. Kinesthetic awareness. That is what defines whether somebody's good at sport or not. All right? You need to be able to move your body well. Otherwise, you're not going to be very good at sport. So elements of kinesthetic awareness are joint mobility, flexibility, stability, strength in your higher grades, speed, power, agility, and endurance. These are the elements that define whether you're going to play sport well or not. It's got nothing to do with your MRI. So it's really, really important that when this player presents to you, if you're the first port of call, yes, you clear all your bases, but then you insist that somebody qualified needs to cover these areas. Okay, because these are going to be the defining areas as to whether that player is going to be able to perform correctly or not. Right, can we show a slide? Now, just while we're getting that going, that previous slide that I was showing with all of the trainers' criterions, the majority of us won't know what those tests are, right? So in that scenario, you need to be saying to the trainer or the physio, listen, what fitness tests have we done? What elements have we looked at? And the important thing is to make sure that all of those elements have been covered. Just because they've run on a treadmill doesn't mean that they're fit, doesn't mean that they have cardiovascular endurance. It might mean that their power is not good. So this is a bit of a long document, and I'm just going to skim through it. Unfortunately, I'm not IT savvy enough to be able to put this into a PowerPoint, but essentially there's a subjective component to what we do. This is not really working out as well as I had hoped. There we go. So there's the whole gamut of questions that you're going to ask the person, and then you're going to look at all of your special investigations, what you might have, looking to see if there are any problems at that level. You're going to ask them how they feel at this point in time. Are there any aggravating factors or relieving factors? You're going to get your visual analog scale or your quantifiable pain measure. Ask them if there are any weird and wonderful things that are happening that you need to be aware of. And then from there, often perhaps a surgeon would then say, listen, I'm a bit busy. I've got a lot of patients. I want a movement specialist to analyze you from here. I'm happy with your MRI. I'm happy with your X-ray. I'm happy with the broad presentation that you're pain-free, you're feeling good, you're motivated to go back. So the surgeon stamps, yes. Okay, but it's a conditional yes, because now you need to go to your movement specialists, and they need to clear you further. So from there, if you're not going to be doing this, you need to send them to the physio. They need to look at posture. They need to look at, this is an assessment of the knee. We're about to send this document. It needs to be approved a bit more, but this is 90% the document that is going to be required by all ISL medical staff to be completed prior to sending an application to us for a player to be approved unfit. So what I'm showing you right now might be a document that lands up on your desk at some point in the future. Okay, so it's important that we understand the level of detail that we're going to be asking the clinicians when it comes to deciding if somebody's fit or not. So you're going to look at the various components from a visual point of view, how they present in standing, looking at the various elements that are fairly common with any kind of a knee assessment. From there, we're going to move on to measurement, circumference measurement of the thigh, looking to see if the muscle girths are equal on the injured and the unaffected side. Then we're looking at the kinetic chain from the lumbar spine down, how the hips are moving, how the ankles are moving, all of the other joints within the lower limb. So they're all in there as well. Looking at active range of motion. So we've gone from visual observation, then we've looked at passive movements, and then we've moved on to more active movements. We've looked at muscle testing, if there are any areas within the knee that we're a little concerned about and that we want to check specifically. I'm going to go a minute or two over, I apologize, but I just want to give you a sense of the document. And then we're going to look at all the special tests for the knee, making sure that the ones that are appropriate are checked and that there are no problems there. And then we're going to move into functional testing. So functional testing, if we're looking at the knee joint, we're looking at things like a deep squat. So there are going to be parameters within how you squat that we need to analyze. We're going to look at things like the single leg squat, and we're going to analyze the parameters of the single leg squat. The forward lunge, how is that getting done? The lateral lunge, how is that getting done? Standing vertical jump test, how well the athlete can jump. So these are all measuring elements of kinesthetic awareness, joint mobility, flexibility, strength, power. Drop tests are looking at strength and power, plyometrics, single leg hop test, triple hop jump, static single leg stability test for balance. And then once all these kind of tests that are done in a fairly small area are done, we look at things like the 30-meter acceleration test, how fast somebody can run over 30 meters, looking at their 10-meter, 20-meter, and 30-meter intervals. Agility drills for high knees, for lateral shuffle, for backwards running. Other drills called T-tests, zigzag running, karaokes, zigzag box drill. These are all tests that are performed within about a 15-meter area. And then finally, we look at shuttle run. So this shuttle run, you run between two cones 20 meters apart as many times as you can. Okay, looking at cardiovascular fitness, looking at ability to accelerate, decelerate, change direction, do all of these kinds of things. So there's a lot in the movement sphere that needs to be covered before we say that you're fit to go back. So I think the take-home message here is communication, teamwork, and without a doubt, you are going to be faced with a scenario where somebody is going to ask you if they're fit to go back. And unless you see this kind of stuff, you can't answer that question confidently unless you've done it. So urge the physio or the trainer to please make sure that they've ticked all these boxes. They've really assessed all of these elements of sports-specific fitness. And then from there, if they've all come back clear, then it's very easy for you to give the green signal from there. Thank you very much for your time.